Thank you for joining iMeet. This meeting is now being recorded.
So I'd like to welcome everyone to the AABIP webinar series. I would like to introduce my co-moderator, Ara Christian, and I'll let Ara introduce our session.
Thanks, David. Hello, everyone. Welcome to our next edition of the AABIP webinar series. And on behalf of Dr. Shaw at Harbor UCLA, we are excited to have Kelsey Johnson from Yale University and Dr. Christine Argento from Northwestern University to discuss the popular topic of incorporating an advanced practice provider into our IP practice. Now, before we begin, just a few housekeeping items. Please, everyone, note that this webinar will be recorded and available for future viewing by AABIP members on the AABIP website. We ask that all participants mute your phones to minimize background noise and optimize the listening experience. You can also use the volume control icon at the bottom right of your iMeet window. During the webinar, please use the chat icon at the bottom left of your screen to type questions or communicate with the group. We leave it up to the presenters to answer the questions during the talk, but we will have dedicated time at the end for further questions and discussion. And then finally, you'll see at the bottom left a projector icon, which allows you to toggle between the presentation slides and your screen. Finally, we want to make note that the AABIP does not endorse any specific technologies or products, and that the views expressed by the presenters do not necessarily reflect those of the organization as a whole. So at this point, I'll turn it over to back over to Dr. Shaw to formally introduce our speakers and proceed with the talk.
Thank you. So we have today Kelsey Cameron from Yale New Haven and Christine Argento from Northwestern, and they're going to be talking about a very important topic on restoring your sanity and how to incorporate an advanced practice provider into your IP practice. Thank you very much, both of you, for joining us today.
Thank you, David,
so much for having us.
Yes. I'll start off this evening. Thank you for introducing me, and it's an honor to be talking to you all. And we'll try to address any questions you have as we go along or at the end. So as David said, we want to talk to you about the utilization of physician assistants and nurse practitioners, which in this day are commonly collectively referred to as APPs, or Advanced Practice Providers. And to make sure that we're all on the same page before moving forward, I'd like to start just by reviewing what a PA or a nurse practitioner is and what they can and cannot do. Then Christine will share with you some survey results that show how PAs and APRNs are currently being used in different IP practices across the country, and then get to any questions that we didn't answer along the way. So a physician assistant is probably somebody that you run into in the hospital if you don't already have one on your service. And I'll tell you a little bit about their history in case you're not familiar. But back in the 1960s, when educators and physicians recognized that there was a shortage of primary care physicians, they created this career or medical field. So Dr. Eugene Stead at Duke put together the first class of PAs, and he chose 4 Navy corpsmen with significant medical experience, and he designed their curriculum after the fast-track training used for doctors during World War II. And the first class graduated in 1967. And since then, the profession has grown rapidly. They now work in any medical or surgical specialty, and they work in inpatient and outpatient settings. Their education, just to address that, PA programs accept students with a baccalaureate degree. They often come with varied backgrounds, and often they've had some patient care contact, like they were an EMT or something like that. The schooling is that they're trained in the medical model with about 1 year of didactic training covering everything, pathology, physiology, anatomy. And then they have a year of clinical rotations, which is about 2,000 hours. And at the completion of the program, which is usually about 27 months, they have a master's degree. And then they have to pass a national certifying exam and remain certified by maintaining continuing education credits, and they sit for an exam every 10 years. So when you see their name PA-C, the C is just that they've passed that certification exam. PAs are licensed by the state and usually the same medical board as the physicians. And although laws governing their practice may vary a little bit from state to state, they can practice and prescribe medications in all 50 states. I won't go into the background of nurses because you're probably familiar with that, but I want to touch on the schooling and just how some of those differences, what some of the differences are. So nurse practitioners were traditionally nurses that returned to school for advanced training, and they could get a master's or a doctorate degree. But now there are some fast-track programs you'll see and meet people from where they enter without being a nurse first. They graduate with a nursing degree and either the master's or doctorate. And so those programs vary in length depending on which one they've done. The curriculum of nursing school revolves around nursing theory, which encompasses health promotion, disease prevention, and health education. So it's kind of focused on the person and the overall health and well-being of the patient. And then nurses, they're certified by the state nursing board, or whether they're nurses or nurse practitioners. So your nurse practitioner will be certified by the state nursing board, and the regulations vary between states. So you'll want to check on the regulations in your state. In some states, they have full independence. They can hang their shingle and have their own practice, and they have full prescriptive authority. And then in other states, they need a collaborating physician, like a PA does. A PA always has to work with a collaborating physician. And they may have restrictions on their prescriptive authority or other aspects of their license. So you'd want to know that if you're hiring a APRN or PA, what the state laws are. This is a slide from the AANP. You can check their webpage, and you can go to each state and click on your state, and it'll tell you whether what some of the restrictions are if it's not a full practice state. So if you're looking to hire an APRN, it's helpful to go to the AANP webpage and check that out first. So if you're hiring somebody, you might wonder what their background is, what they're coming into your practice with. Most PAs will have surgery rotations, just like medical students, as part of their training. And so they will have worked probably in an OR and in post and pre-surgical care. So they've had some experience with procedures and first assisting in the OR, doing sutures, stuff like that. So they should have some skill set. NPs don't have much exposure to procedures unless they've graduated from an acute care program. So there are, I didn't mention that there's a couple variations within nurse practitioners. They can attend 3 different tracks. There's adult acute care, adult primary care, and family practice. Both of the adult ones, they cannot see children. So if you had pediatric patients, you might want to consider which education that they had, but probably most of you don't have pediatric patients. And then the adult acute care, they may have some experience. There's some programs that are even having them do bronchoscopy and things like that during their training or some fellowships. So if they're in acute care, they may have placed lines and do all of that during some of their training. But the other 2 tracks will have minimal exposure to any surgical skills. So you'll see different letters after their name saying which one they are and also which certifying body they got their certification from. So you'd want to know that just so you have appropriate expectations when they come in, what their experience is, with procedures. All right. So they both have, PAs and Ps have the same scope of practice, and that includes taking histories, performing physicals, diagnosing and treating illnesses, ordering and interpreting diagnostic tests, developing treatment plans, educating and counseling patients, performing procedures, assisting in surgery, writing prescriptions, making rounds. They can do pretty much anything. And the one main thing I would say is you'll want to check at the state level, as I mentioned before, but you'll want to check at your institutional level if there's any restrictions on those things. So I know, for example, one of the nurse practitioners in Massachusetts isn't allowed to go into the operating room to first assist because they said as a nurse practitioner she needs to take a first assist course in order to even be allowed in there. So that's at the institutional level. Now, each state's Practice Act may vary slightly, but all states require that PAs work with a supervising or collaborating physician, as I mentioned, and they have a written delegation agreement. And some institutions or some states will require that for a nurse practitioner as well. Our institution requires a collaborating physician for the nurse practitioners. And so I've put in here what Connecticut state says about the practice of a PA, and it's fairly representative of most states, so I'll just go through that quickly for you for how that sort of plays out in your practice. So a PA must be practicing with a collaborating physician. That doesn't mean the physician has to be in the room or see the patient. They have to be accessible. They don't even have to be on campus, but they just have to be accessible by phone or whatever. So the physician can delegate any of his functions, his or her functions, within his or her scope of practice to the PA that they feel the PA is competent to do. So what that translates into our practice is that anything that my attendings feel they can, is in their scope of practice and they think I'm competent to do, I am allowed to do that. Then we have monthly or quarterly meetings where we could discuss patient issues or they could review some of my charts just to kind of check those boxes and meet that requirement. The restrictions to a PA are that they cannot operate independently, and then again, you just want to make sure there aren't any restrictions at your institutional or state level. And if you're thinking about incorporating a APP into your practice and you get through the steps of figuring out what a PA and APRN can do in your institution, you might have to go to the higher-ups and pitch a business plan for this. So I just wanted to include some information about reimbursement for APPs. As of 1998, Medicare will pay PA and NP employers for medical and surgical services provided by PAs in any setting at 85% of the physician's fee schedule. And so you can submit the claim at the full physician rate, but the APP's NPI number will alert Medicare to reduce it to 85%. And then Medicaid, TRICARE, and nearly all private insurers follow suit. There are a few things that Medicaid won't let APPs sign for, which is really annoying, but it's pretty minimal. And there are a couple indications where you can get 100% of the physician fee, and those are called incident to and shared visits. I'll just briefly describe them, but to avoid audit, you just want to make sure you review the rules and you're abiding by them. So incident 2 has 3 stipulations. The diagnosis and treatment plan has to have been previously determined by the physician on the patient's first visit, and the physician has to be on site when the patient is being seen by the PA. And then if any new problems arose, then the physician has to be involved because, again, they have to have diagnosed and created a treatment plan. But aside from those caveats, that can apply actually in a lot of situations. think of your Plerex follow-ups and all those sorts of things. The second scenario is called a shared visit, and to qualify for this, the patient must be seen by the PA and the physician on the same calendar day, and then the physician must provide face-to-face time with the patient and document those evaluation and management findings. Simply signing or co-signing the note isn't sufficient. So this comes up in a few less situations, just because if the physician is involved in part of the history, physical, and medical decision-making, they may just write the note and bill for it themselves. But if the body of the note and everything is already completed and there's just a particular reason, maybe the APP said, I don't like the way the site looks, I think you should come look at it, and the physician comes in, does part of the exam, they can go ahead and complete that, otherwise lengthy note and bill at 100%. So I'll hand it over to Christine to talk about some things to consider when you're hiring someone. Different factors, including your fellows, your institution's business plan, and what your exact needs are. Obviously, need to come into play.
Okay. Well, thank you. So thank you all for coming today. I really appreciate the opportunity to talk, and especially to speak with my friend Kelsey, who's really spearheaded this effort to try and organize the APPs that work in the interventional pulmonary community. I think that's a really important endeavor. They are the glue often that holds our practices together. So I think this is a really important talk, and trying to figure out how we can best, make a team effort within the IP community to get everybody working to the top of their license, working as a team, and getting all the work done in a timely and efficient manner is helpful. So let me see, how do I go to the next one? So I think a couple things that you want to think about when you're trying to expand your practice, and you decide that an APP would be the next person as an addition to your practice, you want to think up front and define your needs before putting out your advertisements and thinking about what you're really looking for your practice. And every practice is a little bit different, as we're going to see. But things that you want to really put at the forefront, kind of the major categories are, do you want your APP to be primarily inpatient, work in clinic with you for your outpatients, or work as a combination of the two? Are they going to be confined to one campus, or does your institution work at several different locations where they'd have to be traveling between? And then are they going to be procedural or not? Other things, are they going to be involved with research? That kind of stuff are things that you really want to start thinking about when you're putting together a business plan and putting together the advertisements to hire somebody. So Kelsey actually put together this really nice survey that she administered to the APPs that were working in the IP community at the time. And so there was it 14 or 16, Kelsey, who answered?
16 respondents.
So 16 respondents for this survey. And, it just gives a nice kind of viewpoint of who's actually working with our IP community. So the first question is really straightforward. So are you a nurse practitioner or a physician assistant? And it turns out that it's like a 60-40 split. And so that's kind of interesting. So there are 62.5% really nurse practitioners and 37.5% physician assistants working in the IP community. Most of them have worked for just a few years, and I think that makes sense because most of the IP practices have just kind of started getting rolling in the last few years. But there are almost half of the APPs within the IP community that have been working for more than 5. So again, it's kind of all over the place. And you'll see in the next few slides that our practices are all really different. And I think that's going to be changing over the next few years as we start streamlining and getting a lot of the IP practices to kind of look at least a little bit streamlined and similar to one another. So again in the survey, so how many attending physicians are part of your IP practice? For the most part, I thought this was a surprising answer. I thought most IP practices were pretty small, so 1 or 2 attending physicians. But it turns out that most of the APPs working in the IP community are working with 3 or 5 attending physicians. So I was actually really surprised by that answer. And then the next one is not surprising at all. Most IP practices really have 1 fellow. There are a few programs that have 3, and then 1 or 2 fellows. Most programs have a fellow. There were a few during the survey period that didn't have a fellow at all. And so those would be the newer practices. This part here, again, is not, I think, surprising, and just kind of talks to the variability and the diversity of how we've all set up our practices and how they're very institution dependent. So the next question was what percentage of your day is spent caring for inpatients? And it really varied. It was relatively equally split between 25%, 50%, and 75%. And so we see this really big variety. And then what percentage of your day is spent caring for outpatients? It looks like, according to this survey, that most of the APPs spend 20% or less caring for outpatients. So I'd say most of us are utilizing our APPs to help us with our service and inpatient. And so just thinking about some of the more common procedures that we do in interventional pulmonary, she also asked, what procedures do you take part in? And so, thoracentesis, I think, is far and away the most common, along with the other pleural procedures, so tunnel pleural catheters and chest tubes. Bronchoscopy is less common. Perc trachs are less common again. And then not being very procedural, so not doing any of the common procedures, would also not be terribly common as far as the IP community is concerned. And okay, so there was a question here that talks about so the question is, maybe those are shared APPs. Don't think many places have more than 5 IP physicians. Kelsey, do you know the answer to that, if they were shared?
Yes, so I wonder if I didn't, specify the people taking this are working in IP practices, but they may be working with multiple pulmonologists alongside of the IP physicians that they're working with. And my other thought was, if there is an institution that has 5 attendings, they probably have 2 APPs.
Right.
So that could be augmented by one location having 5. I don't know of any. But
MD Anderson
probably.
MD Anderson and Cleveland Clinic would certainly have 5.
5. Okay, so then they would have multiple APPs that then would have might have taken the survey.
Yeah. And so, kind of getting closer to the end, are you involved in research? It was close to a 50-50 split. So some participate, some don't. And billing, it seems like most of the APPs will bill for patient visits, but they don't tend to bill independently for procedures. And I think that also makes sense with the scope of practice and just how we're doing things. And we'll take a little poll later to see in the audience who's actually billing independently and who's billing with the attending physicians. And that's kind of one of the things that I'd like to discuss in general is, are we utilizing our APPs to truly act as extenders? And so are we allowing them to bill on their own and act independently by doing these procedural things and billing on their own? I think that's kind of up for debate. Is it better for us to bill and kind of peek our head in for the key components of the procedures, or have the APPs bill independently and do the procedures all on their own? So I'd like to open that up for discussion in just a few minutes. And then this is really the last slide that we have, and it's just theorizing kind of a daily practice pattern for a mid-level provider. And so, I think most of the people on this call would agree that, whatever your procedure would be, I think for most of us the way it works is you get a consult for some procedure, whether it's a tracheostomy or a thoracentesis, and either the fellow or the APP will review the labs and the medications, kind of put in orders. And then the question is, do they assist with the procedure or do they perform it independently? And then they kind of serve as the closer of the loop, so to speak, so that they communicate with the team, make sure that everybody knows what happened, and then follows up results and post-operatively to make sure that everything went well. And I think this is a pretty standard way that we're using these advanced practice providers. But I think I'd like to hear from some of the audience members about what they think, how they think that they can best use their advanced practice providers, if anybody has any comments, because I think it's something that we struggle with a lot, how to use them so that we become efficient as a practice. They're working to the top of their license and have a successful and fulfilling career. And yet we get the job done and bill as much as we can, because in the end, medicine is still a business, and so we're still being pressured to, get RVUs and that kind of thing. So I don't know if anybody in the audience wants to put together, a chat box phrase and see how they utilize their APPs, or if they think that, using them as an extender is easier, or kind of the physician should always be there at least for the key components of the procedure, and they kind of use this to then make their day a little bit more efficient.
Yeah, because I think, Christine, on this slide you can see the left scenario. It's not likely that they're going to be a one-man show doing the tracheostomy. It's
Right.
Maybe they're doing the bronchoscopy portion, or they're just doing, if your APP isn't somebody you're going to use for procedures, they're still doing a lot of the care coordination around it, and can write the consults or not, whatever. And then on the right side where you're talking about a thoracentesis, that may be something you want them to totally offload, and they do that, all the thoracenteses that come in, and then they're acting more as the extender and independent. And I don't think there's any right and wrong. I think all these institutions are doing some combination or version of this, what fits best for them. And so that's one of the key things, I think, in thinking about what you need in your practice and how you want them to function.
Yeah. And I think this is really how most of us will end up growing our practices. So if we start a practice, usually the second person to come into the IP practice will be an APP rather than a second physician right away. And I think, that's how we grow the practice together. And so initially there's some training. And so initially the physician will be there all the time just to make sure that the APP has the specific requirements for the procedures that we are familiar with and that we perform all the time. But then hopefully it develops into a role where the APP is truly acting as an extender and working independently. So the other thing, and Kelsey, I don't know, you mentioned a little bit about how some nurse practitioners, there's two different pathways. They have a, kind of more of an adult and family practice pathway, and then there's an acute care pathway. And I think that's really important. So if you are hiring a nurse practitioner, that's something you want to think about. And I think in the interventional pulmonary world, you're going to want to probably lean towards the person who has the acute care background, because they'll be, more familiar with procedural type medicine and critical care type medicine, which I think bodes well for an IP practice. I was speaking with one of a former APP that I worked with at Emory. So, and she's wonderful. So she's a nurse practitioner who went through the acute care pathway, and she actually has privileges to assist in the operating room. She can perform bronchoscopies, all the pleural procedures. She assists with tracheostomy as well. She said that one of the things, which I didn't know, was that she doesn't have independent prescriptive authority. And because of that, she's allowed to do a lot more things, and it's really regulated more at the hospital level than at the governmental or state level. And so I think that's how, that's maybe something to consider also when you're hiring somebody, if that's allowed. But because she doesn't have this independent prescriptive authority, she really works under the physician, and so the physician decides what is appropriate for her to do, and what she's credentialed to do goes through the hospital alone. So I thought that was an interesting piece of information.
All right, we've got some good questions down here. And I
well,
was
at this
going to
time,
say,
sorry if I can interject real quick,
yeah.
Christine and Kelsey, is I know that we really wanted to have a lot of time for having question and answers. Are we okay at this point to open up questions to the floor and move along in that phase? Okay. So while we're getting some questions going, I just wanted to remind everyone in the audience, the AABIP has a newly formed Advanced Practice Provider chapter, and we would highly encourage all of you to have your APPs join the AABIP as well as join the APP chapter, and the information is available on the screen. It's through the AABIP website. So if you don't mind, I'm going to start going through some of these questions and ask you guys as our experts to answer some of them. So Carla Lamb, she has asked, sorry, just clicked past, but when you're forming a business plan and trying to incorporate an APP, what is the average salary that you would need to incorporate for recruitment?
So that's a great question, and I had no idea what the answer was, because I think it varies obviously a lot, like any salary. It's going to be by location. And then I know for some institutions, so I'm hired by Yale New Haven Hospital through the surgical services, and often the surgical services portion of the hospital reimburses or pays a little bit higher salaries than some of the medical. So those two things would, I think, play in hugely. I did ask the people that answered this survey what their salary is, including a bonus if they get one, because it was a little complicated to break it down into their salary and bonus. And so I'll share that with you. Again, this is just a small snapshot, and I don't have any more details other than I gave them $10,000 increments, 90 to 100, 100 to 110, 110 to 120, 120 to 130, 130 to 140, and greater than 140. So it was really, really evenly split. And then, of course, this is going to play into how many years they've been there. And we know about half of people have been in their institution for, or in their IP practice for 5 years. But 20% made 90 to 100, 15% made 100 to 110, or 110 to 120, or 120 to 130. So it's very evenly split between that 100 and 120. And then there's a few people making 28% making 130 to 140, and some lucky person out there is making more than 140. I don't know what the number is. So that's, a huge split. Again, we had about 50% of them being in their practice for 5 years, and 5 of them were above that 130. We're in that 130 to 140 range. I suspect those are the 5 that have been there a long time. So anybody newly starting, there was a couple that had been there less than a year, they're probably in that 90 to 100 range. I hope that helps.
Great, thank you. And then we have a couple of questions that are somewhat related. I'll start with this first one, which is, do you think that APPs are generally satisfied in an IP practice? And one of the correlates that goes along with that is, how do you incorporate them within an IP practice when you have mixed groups of providers, including attendings and fellows and other trainees? How do you keep them all sharing that space and happily involved with all the different activities that are going on?
Mm-hmm. So
That's
Kelsey, do you want
question.
to take the first one, and then I can jump in for the second part?
Sure, yeah. So I think I asked APPs that are in the chapter what brings them the most satisfaction and what kind of gives them the biggest headache and what's kind of keeping them there. As you can see, 5 of those people had been there for 5 years. Was it 5? Am I getting the right number? But that's fantastic. You're going to teach them a subset of skills or a subspecialty of skills. So after you've invested that time, you certainly want to keep them around. Most people really enjoyed the procedures, and I think unfortunately if you have a fellow, that's going to compromise some of the number or high acuity procedures they're going to do. But I don't know that they need to do in most practices, I highly doubt they're doing rigids. Only a few practices are probably having them do tracheostomies. A lot of them are doing pleuresis, chest tubes, and thoracenteses, which there's usually plenty of for a fellow. So I think getting them some ownership of procedures if they want it. And clearly that's a discussion you'd have when you hire them, because there's certainly APPs out there that are more interested in the patient education and care side and aren't interested in doing procedures as much. So you would want to find that out in the first place. But most people's answer was that they really enjoyed doing procedures. Their biggest headache and what bothered them the most about their practices were being overworked, which, I think this is such a growing field that all of us are a bit overworked. And the other thing was doing things below their skill level. They mentioned that they would like a nurse coordinator often in their program because they were doing some scheduling and different tasks that a nurse coordinator really should be doing when they could be doing the patient care and procedures. So I think those are the 3 main takeaways after asking people their thoughts, was just having some procedures if they want them, and trying to make time for that and space for that, and making sure that they're not doing, a nurse coordinator's job and you're paying them an APP's salary. And, yeah. Go ahead, Christy.
I think for the second, that was great, Kelsey. I was so glad that you had met with the APPs recently at CHEST while in Toronto. So that was very timely. I think for the second question, it's a balance, and it's going to be different from institution to institution, and part of it is going to depend on what your APP is really interested in doing, as Kelsey was saying. I think if your APP is kind of like the majority of the ones that are working within the IP community, when they first start, and we just had a new PA start with our practice about a year ago now, and that was a little bit challenging in the first few months when she started in September, and so our IP fellow had started in July. And so at that point, I think by September, he was starting to feel pretty comfortable with thoracentesis, chest tubes, and it was still working on Pleurex catheters. So we started her training really with pleural procedures, and then she did some bronchoscopy training with us on the simulators to get her up to speed, and some muscle memory there to learn her anatomy and feel comfortable. And then she came with us for bronchoscopy kind of in the gaps when the fellow is busy with something else and you're trying to divide and conquer. And I think that's a common thing. I feel like most of the APPs do trend more towards the pleural procedures because there's a lot, and they can kind of learn those procedures and then transition into more of a teaching role. And so I think that tends to be a little bit easier. The bronchoscopic procedures are a little bit harder because there's just more people in line. So you have your interventional pulmonary fellow, and if you have pulmonary critical care fellows, those people also want bronchoscopic experience. And at least here at Northwestern, we have emergency room residents, anesthesia, critical care, and thoracic surgery fellows rotating with us as well. And so those people are all in line for the bronchoscopic procedures because they want, fiber optic intubation experience and that kind of thing. And so I think the bronchoscopic stuff is a little bit harder. What we started doing was just rotating between the people. So while Christy was training, she would do one bronch, and then it would be the IP fellow for the more complicated ones. But for the basic bronchoscopy, or she would do the airway inspection, and the IP fellow would kind of take over for the EBIS portion or that kind of thing. And so we did a lot of rotating to try and just get everybody trained up and make sure that there was plenty of procedures to go around. We also didn't have our pulmonary critical care fellows rotating with us in the first 3 to 4 months while Christy was training, to try and get her up to speed before we had other people kind of competing for the procedures. So I think that's how we've kind of managed to get her trained, and then she's in a teaching role. So then we started watching her, supervising her, teaching others how to do a lot of the pleural procedures. I think for our APP, the pleural procedures is something that she's been able to kind of carve out as her niche and her area of expertise. So our patients often come back. We see them in clinic, we see them for their procedures, and that's kind of, she's taken over that as her baby. And I think that's nice. She gets a lot of pleasure and satisfaction out of that. And then the teaching role, as with the fellows, is also helpful. So I think having them be able to specialize can be a little bit helpful, but you have to also play to their strengths. So our APP came from thoracic surgery, so she also comes to the operating room with us for pleuroscopy cases, and she's the one who scrubs in and will teach our fellow how to do, essentially for her it was what VATS was. And so she helps a lot with the incisions and how to suture and how to hold the camera and that kind of thing is her area of expertise. So I think kind of working to the strengths of your specific provider can be really helpful.
And I know when I took, thank you, Christine, I would, just to reference my own personal experience, I know we have a lot of questions, so I don't want to spend too much on any one, but when I was hired, I was asked, do you think you could commit a certain amount of time? Do you think you could be here for 5 years? And, of course, barring anything, who knows what happens in life. But somebody that's not transitional, because there is so much specialty training. And then also I was asked, this is very specialized. Are you okay with that very specialized, practice? And that's definitely the case. But I take a lot of pride in one of the attendings I work with says his living will says that I'm the only one that can do his thora because I'm, quote, the most gentle. And I take a lot of pride in something like that. And patients that request me. And so even though most of my day is spent doing thoracenteses, I take a lot of pride in it. And I don't feel, resentful of that being the main procedure in my day. And there was something else I was going to say, but I don't remember what it was.
One of the other questions that was asked was, let's say you decide that the right move is to add a PA or a NP to your group. How do you go about trying to find that person?
So that's a great question. I don't know, Christine, how you guys managed to get Christy, but my experience was that they advertised at the PA program in my area, and the PA program knows their alumni or their upcoming grads. So if you have a PA or NP program in your area, certainly you could reach out to them for either a new grad or their alumni network. And then there is the AAPA has a job posting, so anybody looking for a job that's a physician assistant might go there and look for a position. And I think the nurse practitioner side of things, there's different bodies that they belong to, but there's just pretty much one for PAs. There's a national one, the AAPA, and then state ones. So you could advertise through their advertisement boards, and then usually your hospital will have somebody in charge of recruitment as well, and sometimes they'll go to those conferences and recruit people if people are willing to move or relocate.
Mm-hmm. basically how we did it too. We went to the schools, so the PA schools and the nurse practitioner schools, to try and look for people who would be newer grads. Christy ended up coming to us. The thoracic surgeon she was working with was retiring, so she kind of actually put out feelers to us and had interviewed for the thoracic surgery department here, and so that's how we found her in particular. So it's also kind of asking around to some of the colleagues, like you can ask ENT, thoracic surgery, and pulmonary. The ICUs are a good place to look because that's where there's a lot of the nurse practitioners come from there. And so that's kind of a good resource also within your institution.
Great. And we have a question from Ali Saeed, where he asks, what's the average number of patients seen by an advanced practice provider in an 8-hour clinic day?
That's a good
question. What's the typical volume that they might carry?
So I don't know. I saw she was on the line. Margie. Oh, and you're not even muted. Margie, if you're on the line and can speak to it, she is a APRN and has a clinic day. Margie, do you know how many patients you see in a day?
I'll try to find Margie and unmute her. Otherwise, she can just type in the...
Or she can answer in the text box. Yeah.
Right.
Hello?
Margie?
Yes.
Yeah. Okay, now you can hear me?
Yeah.
Okay, sorry. There's technical difficulties over here. It ranges, it's a wide range because for our practice at Chicago Chest Center, I do not do procedures because we do have a lot of interventional pulmonologists in the group. We have 5. And so I usually stay in the office setting. I see patients outpatient in the office, in the clinic, as well as round at some of the hospitals that we're at. So it can range anywhere from, I can see 8, I can see, 12, I can see, depends on if you add the rounding in or going to, I do general pulmonary, so I go to the, SNFs or the nursing homes, but I can see on average probably 10 to 12 a day. And I do a lot of education in the office. So it's a little different compared to the university settings and the procedures, I think.
Okay. Thank you, Margie.
Yeah, thank you.
Great. Thank you. We have another question from Carla Lamb asking about procedural requirements. Are there any societal guidelines? We obviously have pulmonary societal guidelines and interventional pulmonary societal guidelines on procedural requirements or numbers. Are there any from the APP professional societies?
So there's a lot of flexibility here. There are 2 main guidelines. One is going to be your institution. In order for them to be credentialed, we'll usually have a number. It may be 5, it may be 25, but for them to apply for credentials at your institution, they will have to show that they've been proctored on a certain number, and the physician has to sign off on that before they're credentialed to do them independently. And then the second restriction would be that's really the main one. The second restriction is just that you, as their collaborating physician, have to say that they're competent. So it's kind of on you. If the person's skill set is such that you think they need 50, then they need 50 before you delegate that to them, even if your institution said they only need 25. The societies don't have a set number. There's some literature out there on APPs doing procedures in emergency rooms and showing more that there aren't bad outcomes, that they provide just as good of care and procedures, but there's not as much into the training of how many they need. Most PA programs have instituted minimums for them to graduate, so they have to do a certain number of IVs, lines, thorax and TCs. But they're mostly just following the physician models. They don't have their own research out there that I know of.
Yeah, and I think the same holds true as far as the ICU. So they do kind of the ICU procedures like the lines and that kind of stuff. It's all, based on numbers, but most of it's just institution dependent. When I was speaking with my prior nurse practitioner from Emory, she's actually become the lead NP there at their institution, and so she's actually setting up her own competencies, and so I think that's something that's probably going to start coming down the pipeline, and she's based them off of kind of the medical ones that we use for our IP fellows. So she uses like the EBIS stat, and she's made up her own kind of checklist and such for thoracentesis, chest and thoraxes. And so her with her physicians are kind of going through, and during training will credential these people based on their skill set and these tests that she's kind of put through. And so she's kind of formalizing that with her institution, but for now everything is very institution dependent. And so it varies. And some institutions will kind of credential you up front and then expect the physician, the collaborating physician, to then sign off formally to allow the credentialing to take place officially and for the APP to perform these procedures independently.
Great. And then at this point, we have an additional question. Do you guys have any insight that you can share with regards to the billing and reimbursement as to where the 85% number comes from?
Like most things in reimbursement, I have no idea where they came up with that number.
Me neither. No idea. I wish I knew.
It's true across the board if they're providing care in a primary care practice. They're being reimbursed 85%. True in procedural practices and inpatient, true in surgical practices. So I don't know how they set that number across the board, but
yeah,
if you can maximize it, then good.
Great. Well, if there's any additional questions from the audience, please type them in. While we're waiting, I'd also like to mention that Kelsey and the other advanced practice providers in the AABIP have been doing a fantastic job with the APP chapter, and they have some great visions with regards to developing some curriculum, perhaps sharing protocols or other experiences that they have in their work environment. We would really appreciate input from any other individuals in the AABIP who have thoughts as to what would add value to their APPs to join the AABIP and get involved, and what would be of value to your practices for our APP chapter to know about and perhaps address. So if there's no additional questions, any closing remarks, Kelsey or Christine, before we wrap up?
No, just that, again, I really appreciate this opportunity to talk to you guys, and I've tried to gather as much information from my colleagues as possible and share all of that and not just personal experience. So if you have any questions or you're specific to your practice and you're looking for something specific, certainly feel free to email me and I could maybe help you get in touch with an APP that's working in a nodule clinic or an APP that's working and doing tracheostomies on their own, because they cover this, broad spectrum. And so if you know what you're looking for and kind of want to talk to somebody in that field and how they got to that place, let me know. I'd be happy to connect and give you any of my own personal experience or connect you with anybody.
Yeah, I would echo that. I would just say thank you so much, all of you, for being here. We really appreciate it. There's not a lot of literature about this. It's a new field, and so there's remarkable variability. So I think everywhere is doing their own individual thing, but I think over time everybody will come a little bit closer and have more standardized practices. And hopefully, kind of with this APP chapter, we're going to be, encouraging education and different competencies, making sure that everybody's on the same page when it comes to this, to our IP procedures. The APPs add such tremendous value to our practices that we really need to make sure that we're talking and communicating with these groups to make sure that everybody is satisfied and having a really great, fulfilled career. So thank you so much. Feel free to reach out to us anytime.
And just for added clarity, the website that Kelsey and Christine were referring to earlier is www.aapa.org. And also our next upcoming webinar will be advertised shortly. That'll be on December 12th, and that'll be Dr. Dan Sturman from NYU talking about how to build your academic career in IP. Thank you, everyone, for joining us tonight, and have a great evening.